All right. Well, Greg, thank you again for the invitation, and it's a pleasure to be with all of you this evening on this very chilly evening in Chicago to talk about OCT and specifically OCT for a variety of neuro-ophthalmic disorders. This is a largely show and tell presentation, not a ton of text, mainly cases and pictures. So these are my disclosures, and the key points of what I plan to talk about this evening are as follows. We're going to begin with a discussion of OCT, probably for one of the most common reason that most of us in neuro-ophthalmic practice use OCT, and that's a differentiation of papilledema versus pseudopapilledema. From here, I'm going to talk to you about OCT findings with both chiasmal as well as retrochiasmal disorders. And then from there, we're going to finish up talking about OCT in a variety of neurodegenerative diseases, including multiple sclerosis, Parkinson's disease, Alzheimer's dementia, and then finally, some of the work that we've been doing recently as it relates to traumatic brain injury. So I'd like to begin with a definition of papilledema. All of us remember this in a similar way that papilledema, by definition, is swelling and elevation of the optic nerves due to elevated intracranial pressure. So an elevated, swollen optic nerve, both of these findings due to elevated intracranial pressure. Now, in contrast, pseudopapilledema is nothing more than an anomalous nerve. It's a nerve that you're born with, but is elevated without optic disc swelling. And one of the features of pseudopapilledema is a small or absent cup. And these individuals may or may not present with optic disc drusen. So before we get into the OCT findings, I'd like to talk a little bit about the stages of papilledema. And I think that most of us use the Friesen scale that was developed back in the 1980s. So grade 1 papilledema is one of the more difficult diagnoses that we're called upon to make on a regular basis because the findings are very, very subtle. And as you see in this photograph, as I'm pointing out here, the characteristic of grade 1 papilledema is this C-shaped optic disc swelling that spares the papillomacular bundle fibers. Grade 2 papilledema is more or less a circumferential corona of optic disc swelling. So you get the C-shaped edema plus involvement of the papillomacular bundle fibers. Grade 3 is all of the findings of grade 2, but now we begin to see the major blood vessels away from the optic nerve being obscured. Grade 4 is all the findings of grade 3, but now we begin to see the major vessels on the surface of the optic nerve being obscured. And then finally, grade 5 is where essentially there is obliteration of all optic disc surface detail. And it's at this point where you begin to see the filling in of the optic cup with axoplasmic debris. More on that later. So OCT has really helped us in the evaluation, the initial diagnosis, as well as the ongoing monitoring of individuals with papilledema. And some of the common findings I listed for you here, such as an increase in the thickness both of the retinal nerve fiber layer as well as the rim or the minimum rim width. You have an elevated optic nerve. You have maintenance of the central cup. The cup may very well be elevated. It will be elevated above the plane of the retina. And that maintenance of the central cup holds true until very late in the disease process. Oftentimes, there is the appearance of subretinal fluid that is adjacent to the optic nerve that takes on the appearance of a recumbent V sign or a lazy V sign. And I'll show you some examples of that in just a moment. One of the common findings that we see now, that we've come to appreciate now, not just with papilledema, but with anything that results in a swollen optic nerve, is the presence of peripapillary retinal or choroidal folds. And these are typically on the temporal side of the optic disc. And then finally, something that I think is most helpful, and that is an inward deflection of the RPE Brooks complex. And this really goes along with the flattening of the posterior sclera that we commonly see among individuals with elevated intracranial pressure, particularly with idiopathic intracranial hypertension, in looking at the eye, looking at the globes with an axial cut on MRI. And this inward deflection of the RPE Brooks membrane complex is found in roughly 2/3 of individuals with papilledema. So this is a photograph. These are pictures that are from a very useful paper that was published a couple of years ago in the Journal of Neuro-Ophthalmology by Pat Sibony and colleagues. And what you see on here on the far left side, this column on the far left side, this is what the optic nerve is supposed to look like. These three are normal optic nerves, meaning that the Brooks membrane line or the Brooks membrane RPE complex can either be flat, meaning that it's going straight across. It can be V-shaped, meaning that it's going down or away from the surface of the retina, as compared to these findings, the W, S, and dome-shaped configurations. So a very simple way of thinking about this is that under normal circumstances, the Brooks membrane complex should be at very least going straight across or flat, or going down. If it's bowing inward in any way, shape, or form, that's abnormal, and that's suggestive of elevated intracranial pressure. So here's a case of a 32-year-old woman with progressive headaches, worse in the morning than in the evening. Her BMI is significantly elevated at 41. Along with her headaches, she has a constant perception of synchronous pulsatile tinnitus, which means that she has this swooshing sound in her ears that pretty much goes along to the beat of her heart. Visual acuities are normal, 20/20 in the right eye, 20/20 in the left eye. So here, looking at the appearance of her right optic nerve, we see what is at very least grade 2, maybe encroaching on a grade 3 papilledema, where we have the circumferential corona of optic disc swelling, maybe with a little bit of obscuration of the major retinal blood vessels just away from the optic nerve. And then here in the fellow eye, we see similar clinical findings, circumferential corona of optic disc swelling, maybe with a little bit of obscuration of the major vessels away from the optic nerve. Now, looking at her brain, what you can see here is that structurally she looks fairly normal with the exception of this flattening of the pituitary gland against the floor of the cell. And that's what I'm pointing to here. This is the characteristic empty cellosine that we see with elevated intracranial pressure. And the reason that you get that is because the pituitary gland is very, very spongy. It's almost the consistency of jello. So that as pressure is building up within the subarachnoid space, particularly in the setting of idiopathic intracranial hypertension, it's not going to create an abnormal presentation in the way of the ventricles. There's no ventriculomegaly, but there will be flattening of the pituitary gland against the floor of the cell. So that's the classic empty cellosine in the setting of elevated intracranial pressure, notably with idiopathic intracranial hypertension. So here we can see the nerve fiber layer plots of this individual. And there is this increased thickness, almost in a global fashion. Average nerve fiber layer thickness in the right eye is 228 microns. And in the left eye, it's 161 microns, maybe with a little bit of sparing of the temporal fibers here in the right eye and here in the left eye. Now, this is the morphology of the optic nerve as appreciated with a raster scan. So what you can see here are a couple of things. First of all, the entirety of the optic nerve head is elevated above the plane of the retina. The plane of the retina is down here. We can see that everything is elevated. In addition to that, you can see that the optic cup is preserved. It's elevated above where we would normally expect to be, but nevertheless, it's preserved. Now, what I'm showing you here is this inward deflection of the RPE Brooks complex. So this dotted line that I've drawn in below on the nasal side of the optic nerve, that's essentially the plane of the Brooks membrane line or Brooks membrane complex that we would expect to see under normal circumstances. But what we see here is in the second dotted line, this inward deflection of the RPE Brooks membrane complex. And then finally, what I've carved out for you with this V-shaped sign is this fluid that's accumulating within the subretinal space. So this is the inverted or recumbent V sign here on the nasal side of the optic disc, and then here as well, this fluid that's accumulating on the temporal side of the optic nerve. So elevated optic disc, presence of the central cup, inward deflection of the RPE Brooks complex, and then finally, this recumbent V sign that we see as it relates to peripapillary subretinal fluid. Now here's another case of an individual with idiopathic intracranial hypertension. This is a 29-year-old woman. Progressive daily headaches, maybe a little bit worse when she wakes up in the morning, slight dissipation toward the end of the day. She also complains of synchronous pulsatile tinnitus, this whooshing sound in her ears that goes along with the beat of her heart. Her BMI is significantly elevated at 36, and her visual acuities are normal, 20/20 in the right eye, 20/20 in the left eye. Now looking at the optic nerves, right eye is on the left eye is on the right. What we see is this C-shaped corona of optic disc swelling in the right eye, as well as in the left eye, consistent with a grade 1 papilledema. And looking at the OCTs, what you can see here is that both optic nerves are significantly elevated, both the right eye on the left eye on the right. And then particularly here in the right eye, you can see that there remains preservation of the central cup. But what I particularly want to point out to you with these arrows that are coming in now is this slight inward deflection of the RPE Brooks membrane complex. This is what is commonly referred to as a W configuration of that inward deflection. And the reason that you get that is because this area that I'm pointing to here in the right eye below the optic nerve, here in the left eye below the optic nerve, this is the subarachnoid space of the optic nerve. And the subarachnoid space of the optic nerve is directly contiguous with the subarachnoid space of the brain. So if you have pressure building up within the brain, this pressure is going to translate itself along the distribution of the optic nerve. Essentially, it's going to dam at the lamina cribrosa. And one of the common findings, one of the common sequelae of this is the inward bowing or the inward deflection of the RPE Brooks membrane complex. Here's a 28-year-old woman, also with idiopathic intracranial hypertension, chronic daily headaches, synchronous pulsatile tinnitus. BMI is significantly elevated at 39. Above 30 is considered to be obese. Above 40 is considered to be morbidly obese. Visual acuities are entirely normal, 20/20 in the right eye, 20/20 in the left eye. And looking at the optic nerves, we have what appears to be at least a grade 2 papilledema in the right eye, perhaps encroaching on a grade 3. And then here in the left eye, very, very similar clinical findings, at least a grade 2, as evidenced by the circumferential halo or corona of optic disc swelling. Now, looking at the OCTs, what you can see here is that both optic nerves are elevated. Right eye's on the left eye's on the right. There is some preservation of the central cup here in the right eye, here in the left eye. We also see this inward deflection of the RPE Brooks complex going in the right eye, also going in the left eye. But if I blow up the left eye for you, what I want to point out are these peripapillary wrinkles that you can see here is designated by the arrow on the temporal side of the optic nerve. Now, these peripapillary wrinkles are almost, you see this almost universally among individuals with papilledema. But you also see it with other conditions that swell the optic nerve. Ischemic optic neuropathy, central retinal vein occlusion, anterior optic neuritis. So it's not diagnostic for papilledema, but it is helpful in differentiating, for instance, papilledema from pseudopapilledema. It's very, very unusual to see these peripapillary wrinkles with pseudopapilledema. You see them almost uniformly. You see them almost 100% of the time among individuals with true papilledema. Now here's a 41-year-old woman, also with idiopathic intracranial hypertension, chronic daily headaches, synchronous pulsatile tinnitus. BMI is significantly elevated at 46. Visual acuities are normal, 20/20 in the right eye, 20/20 in the left eye. Then if we look at the optic nerves, we see that both nerves appear swollen, edematous, elevated. And looking at the OCTs, what you can see here, first of all, is this inward deflection of the RPE-Brooks complex here in the right eye, here in the left eye. We see that the optic nerve is significantly elevated above the plane of the retina, right eye on the left eye on the right. But what we can also see is that if we look very, very carefully at the temporal aspect of the peripapillary retina, you see this corrugated appearance. And these are these peripapillary wrinkles, or these interretinal wrinkles. Once again, very common with any form of optic disc swelling, and in this case, due to papilledema. Here's a 40-year-old woman, chronic daily headaches, synchronous pulsatile tinnitus, BMI significantly elevated at 44. But we can see that in this case, the vision is somewhat reduced, 20/40 in the right eye, 20/40 in the left eye. We know that that's not typical with papilledema until the very late stages of the disease, where the optic nerve is now beginning to become atrophic, the visual fields are significantly compromised, and in this case, the visual acuity is compromised as well. So looking at the optic nerves, what you can see is that essentially all surface detail of the optic nerve is obliterated here in the right eye on the left eye on the right. And the other ominous thing that we see here is that particularly in the left eye, the optic nerve is looking somewhat pale. So even though we have all of these sophisticated tools now that help us in the evaluation and the longitudinal management of individuals with papilledema, you still need to look at the optic nerve. You still need to go old school, and you need to look at the color of the optic nerves. My maxim is that with papilledema, if the nerve is pink, that's good. Time is on your side. If the disc is pale or beginning to look pale, that's bad. That means that this has been going on for a while. The nerve is becoming atrophic, and you really need to resort to more aggressive means of getting the intracranial pressure down and getting it down very, very quickly. So this again is more advanced papilledema, both right eye and left eyes. What you can see here is dramatic, is very, very significant thickening of the retinal nerve fiber layer, well over 300 microns on average in the right eye, well over 200 microns on average in the left eye. And here we can see, looking at the raster scans, that there is this champagne cork-like appearance of the optic nerve in the right eye, left eye. The central cups are pretty well obliterated and filled in with axoplasmic debris that's been left behind. And here we can see that there is this inward deflection of the RPE-Brooks complex, something of an S-shaped configuration here in the right eye, as well as here in the left eye. So it's not important to be memorizing, well, is that a W? Is that an S? Is that a dome? To be truthful, most individuals have some combination. The important thing is to, going back to what I said before, is the RPE-Brooks complex on plane or going down, which is normal, or is it bowing inward, which is absolutely abnormal? And if it's bowing
Hey, Len,
inward,
can I make a comment?
sure.
Yeah, so go ahead and take a break. And I know sometimes it's like kind of talking to a screen, as we've all done these. What I would encourage the audience to do, if you have this type of technology, is to start imaging optic nerves that are normal, so that you can kind of get a baseline of how that RPE is supposed to look, well, without that inward deflection, because it's always hard to tell on these kind of anomalous nerves. So take a nerve that is absolutely not even questionable and start imaging and look at 10 to 20 different patients to kind of get the normal deflection of that RPE. It's kind of like what I did for gonio. When I got good at gonio, is I was at an ODMD practice. I did it on all the 1 week post-ops. they didn't know what was in post-op care. So I wanted to get good. I knew it'd be wide open because after cataract surgery. So I did it I did it on every patient for 2 weeks. And then that's what made me good at gonio. So I would just say, look, start imaging some of these normal nerve heads so that when you get that one, it's kind of easier to see that deflection.
Yeah, that's a great point, Greg. I could not agree with you more. And certainly for your glaucoma patients, where you're looking at the morphology of the optic nerve, there again, you would expect to see that Brooks membrane complex or that Brooks membrane line going down or going posteriorly as opposed to going inward. Great point. So this is a case of a 32-year-old woman with idiopathic intracranial hypertension. She presents with progressive debilitating headaches of several months duration. Her neurologic exam is essentially normal. She has synchronous pulsatile tinnitus. She has 20/20 vision in each eye, and her BMI is significantly elevated at 38. If we look at her optic nerves, here in the right eye, she is easily a grade 3 papilledema. And in the left eye, she's easily grade 3, encroaching on a grade 4. But the good thing about this case is we can see both in the right eye as well as in the left eye that the optic nerves are somewhat pink. And pink means that they're perfused. And we'll see the OCT equivalent of that in just a moment when I show you the ganglion cell complex scans. And looking at the visual fields, you can see that we have the rather characteristic findings of idiopathic intracranial hypertension, which is an enlargement of the blind spot bilaterally with a little bit of a nasal depression, or what you can think of as a nasal step, very similar as to what you see among your glaucoma patients. So enlargement of the blind spot along with a little bit of a nasal defect. This is the most common visual field that we see in the setting of elevated intracranial pressure, particularly with idiopathic intracranial hypertension. And you can see here that the nerve fiber layer is significantly thickened, close to 380 microns in the right eye, over 400 microns in the left eye. Now, this is the MRI. And the reason that I'm showing you this is when we look at the OCTs, you'll see how the MRI appearance of the globes essentially mirrors that morphology of the posterior eye wall that we see with OCT. So this is an axial cut through the orbits. And this is a T2 weighted image. And with a T2 weighted image, anything that's fluid is going to show up as being very, very bright. So that means vitreous, aqueous, and also fluid within the subarachnoid space of the optic nerves. But what I'm showing you here is this flattening of the posterior sclera that's very, very common among individuals with elevated intracranial pressure. And the other thing that's very, very common among these individuals from a neuroradiologic standpoint is this tortuosity or kinking of the optic nerves within the orbit, along with this expansion or dilation of the subarachnoid space. So you see more of this hyperintense fluid signal within the subarachnoid space. Now, going along with that, what I'm showing you here is perhaps the most common neuroradiologic finding in the setting of elevated intracranial pressure. And that is, once again, this flattening of the pituitary gland against the floor of the cella. So what I'm pointing to here with my arrow is the pituitary gland that is really just flattened against the floor of the cella. Under normal circumstances, the pituitary gland is going to be is going to appear as somewhat of a flat top structure that occupies roughly a third of the lower portion of the cella. But here you can see that the entire cella has been expanded, and now the pituitary gland is flattened against the floor due to elevated intracranial pressure. And this is the chiasm, or the chiasmal bar, that we see suspended above this flattened pituitary gland.
Hey, Len,
So,
just to help out with the audience here, go back to that MRI there. That kind of right below the white arrow there, it's still kind of whitish looking. Is that pituitary gland or is that some other structure?
Yeah, yeah. This area that I'm pointing to right here, that's the pituitary gland.
Okay. And then right above it too, in the black, is that pituitary gland?
Nope, that is the suprasellar cistern. That is subarachnoid fluid. So the chiasm is here. This is subarachnoid space. This is fluid within what is termed the suprasellar cistern. The pressure is elevated here, which is literally now compressing the pituitary gland against the floor of the cella. And that's what you see here with the arrow.
So that very thin white area is your pituitary gland.
Yep, that's it exactly. That's
Okay.
it exactly.
Okay, perfect.
Now, this is the equivalent of this flattening of the posterior eye wall that we see with MRI. And that is the optic disc is elevated. We see that there are these peripapillary wrinkles here on the temporal side of the optic nerve. We see that there is fluid accumulating within the subarachnoid space in the peripapillary region. But what I really want you to focus in on is look at how the RPE Brooks complex is going inward here on the nasal side, as well as a little bit here on the temporal side. So that is literally the equivalent of this flattening of the posterior eye wall that you can see on this axial cut through the globes. And here in the left eye, practically the same thing. Elevated nerve, preservation of the central cup, peripapillary wrinkles, notably on the temporal side of the nerve, a little bit of fluid in the subarachnoid space, here nasal, here temporal, and then this inward displacement of the RPE Brooks complex. So Greg, I think you hit the nail on the head, is that when you're looking at a bunch of normals, you're going to really get that familiarity of that this is a line that should be going straight across or going down. If it's curling in like this, that is a surefire giveaway that you've got elevated intracranial pressure. So put this woman on acetazolamide, 500 milligrams twice a day. And she was very good at losing weight over a period of about 6 months. She lost about 25 pounds, significant improvement in her headaches, as well as her synchronous pulsatile tinnitus. And she comes back to see you 6 months later, and you can see that her optic nerves are settling down pretty well. Her nerve fiber layer is, the nerve fiber layer thickness has gone from close to 400 microns to a little over 100 microns both in the right eye as well as in the left eye. But you got to be careful with this, because with papilledema, if the nerve fiber layer is thinning itself down, that can be for one of two reasons. Either the patient is getting better or they're getting worse. As the nerve becomes atrophic, it will naturally flatten itself out. So you can't just look at the nerve fiber layer as determining whether or not the patient is responding to therapy or whether they're not. Now, looking at the morphology of the optic nerve here, you can see that the nerves are beginning to flatten themselves down. But I'm going to get to the GCC map in, I think, the next slide. But 14 months later, she's now been off Diamox for 3 months. Her BMI has come down to 30. She's headache free. And you can see that there's pretty much a normal appearance of the optic nerve in the right eye, normal appearance of the optic nerve in the left eye, nice pink appearing optic nerves. We can see that her nerve fiber layer thickness has gone from 386 to 97 in the right eye, 442 to 101 in the left eye. But this is the money shot. That's the ganglion cell complex. No matter what instrument that you're using, you're looking for this, the golden halo appearances, or the golden donut appearances, we like to refer to it. That means that the ganglion cell layer or complex is normal. When you see that, you know that you're in good shape. When it's beginning to break down, that's when you have problems. Those are people that are deteriorating. And here again, here you can see that the nerves are This is normal morphology of the optic nerves. And take a look at these Brooks membrane lines. You can see that it's pretty flat, maybe going down a little bit here in the right eye, pretty flat, maybe going down a little bit here in the left eye. And normalization of the visual fields over time. So polling question number one, Greg, do you want me to read this one out?
Yeah, go right ahead. I have it launched.
Great. So which of the following is not an OCT characteristic of papilledema? A, nerve fiber layer thickening. B, elevation of the optic disc. C, a subretinal hyporeflective space between the photoreceptor layer and the RPE Brooks complex, or the recumbent lazy V sign. Or D, an outward deflection of the RPE Brooks complex.
All
So
right.
Greg, let me know when you want me to put the answer up.
Yeah, I'm gonna let them answer. I should have made you co-host, Len. I don't want to do it now because I want to maybe boot us off or anything, but I can see the questions rolling in here. We have a great participation, 78%. I'll share the results here so you can see it, then we'll put the answer up.
Okay.
I have a question that came to me through direct message. Let me see. Does the OCT add anything to what is already obvious from the it says fungus photo, but fundus photo. So does the OCT add anything already obvious then from a fundus photo?
Yeah, I really think it does. And where I think that what it really adds is looking at the morphology, looking at the raster scan. You need the protocol for imaging the optic nerve in the setting of papilledema versus pseudopapilledema is that you pretty much use the glaucoma protocol that everyone is probably used to, but you need to get a raster scan. And specifically, you get the raster scan horizontally. And horizontally right through the center line of the optic nerve. And that's where you can see this inward deflection of the RPE Brooks complex. So you can't see that clinically just examining the optic nerve, but you do see it pretty well with the OCT.
Another question rolled in. How is a brain abscess ruled out?
Yeah, a brain abscess, well, I'm going to answer that in two ways. A brain abscess typically is associated with rapid elevation of intracranial pressure. Now, in those instances, you typically get a hemorrhagic papillopathy, so that there's extensive blood in and around the optic nerve, or there's preretinal hemorrhage. When you see that, worry. That's 911. Those individuals need to be worked up immediately. The good news is that with idiopathic intracranial hypertension, that's very, very unusual. So the other way of thinking about that is when I get the MRI, I'm getting the MRI looking for a couple of different things. I'm looking for the characteristic features of elevated intracranial pressure in the setting of idiopathic intracranial hypertension, which is a flattening of the posterior sclera, which is a distension of the optic nerve sheath, which is a tortuosity or kinking of the optic nerve, and also which is the presence of an empty or partially empty cella with, and this is the kicker, the rest of the brain is normal. With an abscess, of course, the rest of the brain is not going to be normal.
Great. And one more, I just shared the results, but let me get this question in. It came again. You won't see it if you have your chat open because it came to a direct message. What labs are ordered when a patient is on long-term acetazolamide?
Yeah, that's a good point. I think that really most individuals tolerate acetazolamide pretty well. I think a CBC along with a serum chemistry, whichever serum chemistry you prefer, that's reasonable. I don't think you need to go. I don't think that you need to go beyond that.
Perfect.
Now, another question that I get frequently is, well, what if the patient has a sulfa allergy? you really don't have to worry about acetazolamide for individuals with sulfa allergies because it's a different, it's compounded in a different way. So a lot of your patients are going to come in with sulfa allergies. Acetazolamide, it's a different compounding, so you don't have to worry about that.
Yeah, the key with that is that they're really not allergic to the sulfa base itself. They call it I forget, it's an moiety that's on it. It's another antigen that's on the sulfa drug. It might come to me or I might Google it while you're talking. And that's where all the confusion comes from. It's not really the sulfa drug, it's that moiety that's on there. And that's what the patients are allergic to. And that medication does not really have that moiety on there. So that's why they're not allergic to it. And the same thing happens with like the Trusops and the Cosops. Hey, someone has a sulfur allergy, penicillin allergy, or not penicillin, but a antibiotic sulfur allergy. That has the moiety. These medications don't. And that's where it gets really, really confusing. So
great point.
So Len, there's your results for your polling question. 12% did retinal nerve fiber thickness, 4% did elevated disc, 6% did subretinal hyporeflective space between the photoreceptor and RPE, that lazy V, and then the outward deflection of the RPE and Brooks membrane complex was number one at 78%. I think they were paying attention.
Well, that's wonderful. Remember, anything that's going out is generally normal as it relates to the RPE Brooks complex. If it's curling in, regardless of the configuration, that's abnormal. That's elevated intracranial pressure. Great work, team. Okay. So that's papilledema, and specifically the OCT findings of papilledema. Let's move on now and talk about pseudopapilledema. And as I said before, pseudopapilledema I think of as just an anomalous optic nerve. Patients are born with it. They have a small posterior scleral canal so that it results in about 1 million to 1.2 million axons trying to get out of a more narrow space as they leave the eye to go back to the brain. So what does that mean? Well, nerve fiber layer can be thick or it can be thin among individuals with pseudopapilledema. And I've heard it said, well, yeah, but it's going to be a lot thicker with true papilledema. That's absolutely not true. I've seen pseudopapilledema that has with very, very thick neuroretinal rims, very, very thick nerve fiber layer. The optic disc will be elevated. If there are drusen present, you will typically get this irregular contour to the optic disc margin. Sometimes you can actually see the drusen. But what you don't see is you don't see fluid in the subretinal space. You don't get that lazy V pattern. Most of these individuals have a very tiny or absence of the central cup. And then finally is the neutral or negative deflection of the RPE Brooks membrane complex. So what about optic disc drusen? Optic disc drusen are really a consequence of an anomalous optic nerve in that some of the axons have just given up and they died. And the material that's left behind essentially forms these colloid bodies that accumulate within the substance of the optic nerve. And that is what constitutes the drusen. Now, a couple of things that I want to say about optic disc drusen before we go into some cases. One is that over time, the nerve fiber layer will continually thin itself down. The nerve fiber layer will thin itself down, and there's really nothing that you can do to prevent that. The other thing is that particularly in younger individuals, the presence of optic disc drusen is probably the most significant risk factor for the development of non-arteritic anterior ischemic optic neuropathy. And that's particularly in young individuals without an established history of vasculopathic illness, such as hypertension or diabetes. So optic disc drusen characteristics, these are what were published several years ago by the Optic Disc Drusen Consortium Committee, and I'm going to read them for you. Number one, they're always located above the laminar proboscis. Two is they always have a signal poor core. Three is they're typically seen with hyperreflective margins usually on the superior portion of the drusen. 4 is that they can present as both individual as well as multiple aggregates. 5 is that these individuals typically have hyperreflective horizontal lines below the disc drusen, and this may be these may be artifacts that are produced by the drusen as they're forming. And then finally, as these are anomalous optic nerves with crowded optic nerves, you're almost always going to see evidence of something called a peripapillary hyperreflective ovoid mass-like structure, or a FOMS. And do not confuse these with optic disc drusen, because they simply represent a bulging of axons around the perimeter of the optic nerve. And that's what gives you that blurring, that white ring that you see around the optic nerve. And another thing is that anything that produces optic disc edema, or anything that produces a compartment syndrome of the optic nerve, can also produce these FOMS, such as central vein occlusion. We see these sometimes with tilted optic nerves, optic neuritis, ischemic optic neuropathy. So they're certainly not, and of course, one of the most common things that we see these FOMS lesions with are individuals with papilledema. So with that, let's take a look at a couple of cases. Here's an individual who comes in to see you, normal vision, wants a new pair of glasses, looking at the optic nerve. What you can see is absence of the central cup, pretty good color to the optic nerve, no obscuration of the retinal blood vessels around the optic nerve, but what you can see very readily in this case are these excrescences that represent the drusen that are creating this lumpy, bumpy contour to the optic disc. Now, what does that look like with OCT? Well, here is a cross-section, a raster scan taken through the superior portion of the optic nerve. And what I'm pointing out to you here with these arrows are these ovoid structures within the optic nerve, these ovoid lesions with signal poor cores. These are the drusen. So they're embedded within the optic nerve, they're hyporeflective, and they have something of a hyperreflective surround, notably at the apex. Another thing that I'm pointing out for you here with this yellow arrow is particularly here on the nasal side. You can see the same thing on the temporal side. That is a peripapillary hyperreflective ovoid mass-like structure. These are nothing more than bulging axons. They're not precursors to drusen. They're simply bulging axons that are there because of the crowded anatomy of this optic nerve. The green lines are pointing to the hyperreflective horizontal lines that you can see here within the substance of the optic nerve, and once again above the lamina cribrosa. And finally, I'm circling a blood vessel because sometimes people get confused. They say, well, how do I differentiate drusen from vessels? Simple. Vessels are always going to be very, very superficial, such as what I'm pointing out to you here. Another thing is that vessels are going to shadow everything below them. So everything's going to look dark below the vessels. Drusen can shadow structures below, but not completely the way you get with optic disc vessels. So this is, so I pointed out to you here, not only the drusen, but the peripapillary hyperreflective ovoid mass-like structures, the hyperreflective horizontal lines, and the retinal blood vessels. Let's take a look at another case. This is a 33-year-old woman who was sent to me for the evaluation of what appeared to be optic nerve swelling in her left eye. 20/20 vision is in each eye, normal neurologic examination, no headaches, no synchronous pulsatile tinnitus. And looking at her optic nerve, what you can see is it's elevated, absence of the cup, but she's got these very significant, she has these very profound ovoid mass-like structures with that have hyporeflective interiors, or a signal poor core. These are the optic disc drusen. Here you can see a surface retinal blood vessel as evidenced by the red arrow. And then below this aggregate of drusen, you can see several hyperreflective horizontal lines. Here's a 29-year-old woman who was sent to me for the evaluation of presumed papilledema. She's got 20/20 vision, normal neurologic examination, normal BMI. She's got a history of migraine headaches, but no other findings of elevated intracranial pressure, such as synchronous pulsatile tinnitus, transient diplopia, or transient vision loss. So here, looking at her optic nerves, you can see that her optic cups are absent bilaterally. There's a little bit of a blurred appearance to the optic disc margin, both here in the right eye, here in the left eye. If you look real carefully, you can actually see some drusen that are peeking through here as well as here. Now, looking at her B scans, which is what most of us grew up being trained as this is what you do whenever you suspect an individual of having disc drusen. And you can see that sure enough, there are these areas of hyperreflectivity here in the right eye, or here in the left eye, here in the right eye below. But what I think is a much easier way of looking through for drusen, as long as they're hyalinized, as long as they're showing some calcification, is with fundus autofluorescence, particularly with kids. It's hard to get kids to hold still and do a B scan. It's pretty easy to do a fundus photograph. So what you can see here is not only the presence of optic disc drusen that are hyperautofluorescing, but you can actually see the drusen individually. So you can then tailor your raster scan to go through these individual drus. And this is exactly what you can see is here in the right eye, this aggregate of drusen along the nasal aspect of the nerve. Here in the left eye, similar optic disc drusen, particularly here within the nasal aspect of the optic nerve. Disc is elevated, cup is pretty much absent, and the RPE Brooks complex is going down. It's deviating posteriorly. This is a 62-year-old woman who presents to you complaining of a little bit of blurry vision that largely is attributed to her dry eye. She has 20/20 vision, 20/25 vision in each eye, normal neurologic examination. We can see that her optic discs are elevated bilaterally, but she's got this downward deflection of the RPE Brooks complex, both here in the right eye, here in the left eye, and in both eyes, she's got these ovoid masses within the optic nerve with a signal poor core. These are her optic disc drusen. And here's the same thing in both the right eye as well as the left eye on B scan. Hyperreflection within the substance of the optic nerve, right eye, left eye, above the lamina cribrosa. Now, I'm going to finish up disc drusen with this case of a 7-year-old young man who I first had the opportunity to examine in 2013. And I've seen him at least on an annual basis for about the past 10 years. So he presents with 20/20 vision, normal neurologic examination, but optic nerves that look like this. Elevated nerve in the right eye, elevated nerve in the left eye, a little bit of an irregular surround to the optic discs. And if you look real carefully, particularly here in the right eye, you see what appears to be maybe a little bit of drusen that is showing itself here at about the 2 o'clock position, as well as here at about the 11:30 position. Now, looking at his B scans, you can see that there's something hyperreflective going on within the optic nerves here in the right eye, as well as here in the left eye. And he presented to me, and looking at the OCTs, what you can see is that he's got these ovoid lesions within the optic nerve that I'm pointing out to you here. Disc is elevated, absence of the central cup, downward deflection of the RPE Brooks complex, both in the right eye, similar findings here in the left eye. Here's his drusen, and here's his fons. So I told his father, I said, you know, I really, and by the way, he came in already taking acetazolamide, 250 milligrams twice a day. I said, you know, I really don't think that your son has papilledema. Let's put him on a drug holiday and see what happens. So over the years, his discs really, nothing has changed very much. Here he is in 2019. But what we can see now is the optic disc drusen are becoming more manifest. They're easier to see here in the right eye, here in the left eye. Here's the fundus autofluorescence, again, easy to do in kids. And you can see the individual drusen showing up very, very nicely. And the same thing here on the OCT, you can see these ovoid lesions within the optic nerve, hyporeflective centers, along with the hyperreflective horizontal lines below them. And then finally in 2021, you can see that the drusen are becoming more apparent, right eye, left eye, and very, very similar OCT findings. Drusen and hyperreflective horizontal lines. Now, here's the kicker. I think when Greg and I were in training, we were taught, and many of you were taught the same thing, that over time, the drusen become more superficial, that they migrate more anteriorly, and that's really not true. What really happens is that the overlying retinal nerve fiber layer thins itself down. And that's exactly what you can see here, both in the right eye and in the left eye over time, is this progressive thinning down of the retinal nerve fiber layer. Now, if you were to do visual fields, you would see some visual field defect that is going along with this. And the bad news is there's really nothing you can do for it. The good news is that most of these individuals do pretty well. Even though the nerve fiber layer thins itself down over time, most of these individuals function pretty well. So don't get alarmed when the nerve fiber layer is thinning itself down. That's going to happen. It's an expected finding, but understand that this is just something that happens over time among individuals with buried drusen. And you can't put them on eye drops, you can't fenestrate their optic nerves, you really can't do anything to slow this down.
And Len, that's a great point here. Let me do the one question, because it always seems to be a great question. It says, does the OCT, does the OTC, it's OCT appearance of the disc drusen look differ in children versus adults? And I'll pause there on that question.
You know, that's a really good point, because early on, I just saw a kid the other day that had this, you know, with very, very early disc drusen. Nothing was showing up on the B scan. Nothing was showing up on the fundus autofluorescence yet. There were some equivocal areas within the optic nerve that looked somewhat ovoid, but what was showing up within the optic nerve were the hyperreflective horizontal lines. So that's what I go looking for, particularly in younger individuals, because it takes a while for these things to evolve. Remember, kids aren't born with drusen. Drusen are an acquired phenomenon over time. And they're an acquired phenomenon that as the axons are breaking down, this is the axoplasmic material that's left behind.
The follow-up to that or continuation, which you just kind of answered, but I'll just read the question is, are you prescribing brimonidine in patients with progressive visual field loss from disc drusen, even if the IOP is not elevated?
Yeah, you know, that's a great question. And, you know, the answer to that is I used to, but I don't anymore. And I don't for two reasons. One is there's nothing in the literature to support it. Two is that I think, as we all know, brimonidine tends to be somewhat irritating for many individuals. So to put them on a drop that there's no evidence to support that they need it, and to give them some irritation and to create an additional expense for them until someone can prove else, until it can be proven otherwise for me, I just watch them.
Yeah, and it kind of probably goes back to a little bit of some people might be thinking, you know, is there any neuroprotection, you know, to those type of medications? And, you know, we were taught that way back whenever this molecule came out, and it was 0.2%, and then the 1.5, and then the 0.1. But, you know, I kind of look at it as, you know, and that came out like 2000, 2002, we're 2 decades into it, and we're still kind of wondering if there's a neuroprotective property. 2 decades into it, there probably isn't. I'm not saying that's without doc was going with that, but I'm just kind of
Yeah.
adding that kind of commentary. Another one came in a little bit.
I ask my glaucoma, colleagues all the time, and I just get this sort of a shrugging of the shoulders. And it would be great if there was, but I just don't know that I don't know that there's definitive evidence that it's neuroprotected. And if it is, does neuroprotection really help these individuals?
Exactly.
Because it's a compartment syndrome.
Right. Exactly. Yep.
Yeah.
This is go back a little bit back into your lecture. Someone asked, is BMI associated with pseudopapilledema?
Yeah, that's a great question. I'm going to answer it this way. It goes back to Hickham's dictum, as we were all taught, and that is that a patient can have as many diseases as he or she damn well pleases. And I've seen quite a few individuals that have both anomalous nerves that they were born with, and then for whatever reason they develop they develop idiopathic intracranial hypertension. So you cannot simply look at the optic nerve and assume that, well, it's an anomalous nerve, small cup, fits all the character, even in the presence of optic disc drusen, and say, well, then that must mean it's pseudopapilledema. Certainly they may very well have pseudopapilledema, but they can have true papilledema to go right along with it. I think the kicker is, if it's pseudopapilledema, you're probably not going to get the peripapillary wrinkles, and you're not going to get the inward deflection of the RPE Brooks complex. You'll get both of those if it's true papilledema.
We got more questions rolling in, so let's just take them. One is, I have a OptiView OCT and an OCTA. Is an OCTA needed to do, it says a Raster. I think you're probably asking for a raster, RASTER scan. You do not, I believe, need an OCTA. That can be done right on the traditional B scan OCT.
Correct.
Could Dr. Messner explain the idea of compartment syndrome within the eye? What diseases compose of compartment syndrome?
So if you think about the optic nerve, as I explain it to my patients, the optic nerve leaves the eye through a hole in the back of the eye. Now, historically, we used to refer to that as the posterior scleral foramen. More recently, that is called the Brooks membrane opening. But it's that hole in the back of the eye. And if it's small, it means that an individual, we're all born, unless we have disc hypoplasia, we're all born with roughly about 1 million or 1.2 million axons. If that opening in the back of the eye is small, it's like the old adage of trying to fit 10 pounds of stuff into a 5-pound bag. It's going to be more difficult for all those axons to get out of the nerve, and they're going to pile up on top of themselves. That's what gives you the elevated appearance of the optic nerve. As they're piled up on top of themselves, it's going to create a smaller optic cup, or absence of the optic cup altogether. And that that narrowing of the optic cup is literally what is creating a small compartment. So that's why with classic ischemic optic neuropathy, you infarct the optic nerve and there's no place for the fluid to go, and they end up with a full-blown compartment syndrome with acute vision loss, altitudinal or arcuate bundle defects, and then a swollen appearance to the optic nerve, either in total or in sector. But I will tell you that I think we need to be thinking of ischemic optic neuropathy in more global terms, because among particularly your African-American patients that have larger cups, they too develop small vessel disease of their optic nerves. They too develop infarction of their optic nerves, but they don't present with that acute vision loss, altitudinal field defect that is part and parcel of a quote unquote compartment syndrome, because they've just got more room for that fluid to dissipate, I think. What they will present with is a pale appearance to the optic nerve. And that's a whole different lecture, but that's where, we have this interplay at my institution, where we're juggling patients back between between neuro-op and glaucoma. Is this normal tension glaucoma, or is it something else? And it goes both ways. But I guess that's a roundabout way of saying that a compartment syndrome is nothing more than an optic nerve that has a small hole in the back of the eye. Or that's an optic nerve with a small compartment, I should say.
Perfect. You're going to got a couple nutritional here, and I can help out in this arena a little bit. The first one is there any reason to use ginkgo biloba?
What do you think, Greg?
Where some of this is coming in, Len, is that, I've taken the last few years a dive into going to functional medicine courses and so on and so forth. I think ginkgo is a good idea. I certainly don't see any harm to it. What I do know about ginkgo is that, it has an anti-inflammatory action. It has an antioxidant action. It helps with glucose utilization, platelet aggregation, so on and so forth. So, it wouldn't be a bad hurt with that, wouldn't be a bad suggestion. I'm not more of an isolate. I kind of, when it comes to antioxidant, I kind of like a full spectrum. So A to Z, adding in carotenoids and then if you want to target, then go in and do ginkgo. I certainly don't think there's a hurt there to go with that approach.
I think that's a great way of addressing it. I take ginkgo from time to time as well. It's, when I think about picking it up, I take it. I should probably be more diligent, but if it's somewhat protective, then so be it. I think, Greg, we probably agree that it's going to take a while to see good clinical trials coming out of that, very simply because the drug companies don't make ginkgo biloba.
That's exactly it. Yeah, very good point. And then Peter asked here, any supplements to eliminate or reduce these drusen? I thought you mentioned you had a protocol that worked, only adults ? And, the key here, Peter, is that, is the love, you have to understand the pathophysiology, and these drusen, as Len pointed out, are kind of just axons that kind of died, kind of just become fossilized. In my opinion, maybe Len, that may not be a good way of putting it. You can clarify that, but they're a different animal. And when you have drusen of the retina, when you're having complement factor 3 and complement factor H in the arms, and you're having this complement factor kind of inflammatory reaction, that's when you can go with an aggressive type of anti-inflammatory fish oil type of approach. And yes, I have reduced and eliminated drusen in the back of eyes. Not every single patient that comes in, there's probably some bio-individuality out there. But Peter, the answer is these are two different mechanisms, kind of fossilized axons versus a true inflammatory reaction.
Yeah, that's a great point. And getting back, I love that analogy of fossilized aggregates within the optic nerve. Remember, I showed you a case earlier of, when the cup fills in with chronic atrophic papilledema, it's filling in with axoplasmic garbage that essentially eliminates the appearance of the central cup. That's simply another way of saying they develop drusen over time, but in that instance, due to chronic papilledema.
We're all caught up there, my friend. You've got the floor.
Okay, great. So, so getting back to this ring around the disc, I think we need to get away from looking at people with anomalous optic nerves and seeing that white thing, and really become very, and really setting off the bells, because if you look at this stuff on OCT, this is what you see. And this is the FOMs that I was describing for you earlier. And these are nothing more than bulging axons. Now, this just happens to be, and they unlike with drusen, where they occur randomly within the optic nerve, these bulging axons, they go all the way, they typically go all around the optic nerve, almost like a donut. So drusens are excrescences within the optic nerve. The foms you can think of as being an annular donut of bulging axons. All right, so Greg, are we ready for another polling question?
I think we are. So let's roll that out. Go ahead and read it to us.
All right, great. So polling question number 2, which of the following is not an OCT characteristic of optic disc drusen? A, the presence of a signal poor core. B, associated with hyperreflective horizontal lines. C, the presence of a hyperreflective surround. Or D, FOMs are precursors to optic disc drusen.
And I think we got all caught up here on questions. I think this is a good time for me to remind myself. I've been so listening to the lecture that I should be adding the handout. I think I can do that. I'll add the handout to the chat here in a little bit. Format. And see how the polling questions rolling in. Good audience here tonight, nice and active. So this is the interactive part, for this synchronous live. This is why I asked, or Joe and I asked, and Vanessa asked to throw about 4 or 5 polling questions in. Keep it interactive, stay compliant. And so we've got a good reply here. So Len, let me know if you can see these results.
I cannot, but if you want to read them off, that'd be great.
Yep. So as what we have with the outcomes, we have 18% saying presence of signal poor core. We have 14% on the association with hyperreflective. We have 13% with hyperreflective surround. And then we have 56 going with the FOMs are precursors to optic disc drusen.
All right. Well, once again, the majority has won. Remember, FOMs are nothing more than bulging axons. They don't lead to drusen. You can get them with a wide variety of optic disc and abnormalities, optic disc swelling, just tilted optic nerves that are part of anomalous optic nerves. So anything that can bulge optic nerves, those are FOMs. They are not precursors to disc drusen. All right, great. So let's move on now and talk about OCT analysis of retro and retrochiasmal lesions. And I think that I'm just going to tip it off right now. I think that this is really, really cool. And I think that it's something that you need to be aware of as you're getting OCTs routinely, particularly for your glaucoma patients or for other reasons. So,
hey, Len, can you go back one?
Yeah.
Is that the pituitary gland there?
This is a pituitary adenoma that is emanating from the pituitary gland, but what you can see is this bowing of the chiasm directly over this pituitary adenoma.
Perfect, thank you.
And if we go back to high school physics, or I think everybody in this audience has been taught in that if you have a compressive lesion of the optic chiasm, that the characteristic visual field is going to be a bitemporal hemianopia. And you say, well, why is that? And the answer is because the nasal fibers, the nasal fibers that decussate near the central part of the chiasm are more susceptible to pressure changes than those temporal fibers that are going straight back. And you say to yourself, well, why is that? And that is simply a matter of physics, that anything that crosses, if you apply pressure to it, there's going to be a greater translational pressure than if you take a cylinder, you take wires and you run them straight back. So that is purely the reason for why those decussating nasal fibers are going to be more susceptible to injury or dysfunction with chiasmal compression. And so too, these nasal fibers subserve not only the optic nerve, but that ganglion cell layer and the ganglion cell complex that is readily visualized through OCT. So here's a case of a 40-year-old man who came in complaining of vague complaints of his side vision being blurry in both eyes, several months duration, 20/20 vision in his right eye, 20/20 minus vision in his left eye. And these are his visual fields. And I think that we could probably agree that these visual fields are equivocal at best. I don't know that anybody's going to hang their hat on what these visual fields mean. But if you look at these pattern deviations below, you can see that there is something of temporal field loss here in the left eye. There is something of temporal field loss here in the right eye. But if we look at the ganglion cell complex, which you can see, and I'm going to go to the pie charts, is that in the right eye, there is this nasal thinning down of the ganglion cell complex. In the left eye, there is comparable nasal thinning down of the ganglion cell complex. And this is why, looking at this individual's chiasm, I'm going to cut straight to the good stuff. And here is the chiasmal bar that has been deviated upward. This is a coronal cut through the chiasm. This large isodense lesion, this mass that you see below, that is a pituitary adenoma. The pituitary gland itself would only occupy about this much of the cella. In this case, the entire suprasellar cistern has been filled, and you can see this bowing up of the chiasmal bar that is maximally affecting the nasal fibers that cross. Now, this is something that was reported on out of Emory University by Valerie Boost, Nancy Newman, and their colleagues several years ago, as this ganglion cell layer or ganglion cell complex thinning as being an early signature, and oftentimes being more sensitive rather than visual fields in the detection of chiasmal compression. And you can get this not just with a tumor, but you can also get it from trauma. So this is a 31-year-old man who was in a motor vehicle accident, loss of consciousness, vision now has been reduced to 20/40 in the right eye, 20/80 in the left eye. What you can see is that he has this very pronounced bitemporal hemianopia. Left visual field is on the left, right visual field is on the right, and you can see that he's got this bitemporal visual field defect that somewhat spares the vertical midline. But here you can see beautifully on the OCT. And I think it's easiest to look at the thickness maps above. Nasal retina is thinned here. Nasal retina is thinned in the fellow eye. And the chiasm is preserved, but here you can see this large area of encephalomalacia associated with his skull fracture and his traumatic encephalomalacia. So you can get this with with anything that mechanically messes with the chiasm. The most common is a tumor, such as a pituitary adenoma, Rathke's cleft cyst. Sometimes we see these with suprasellar meningiomas, but you can get these with trauma as well. My point to you is that when you see this binasal thinning, think of something going on within the chiasm. Now, what about retrochiasmal lesions? Well, particularly with optic tract and optic radiation lesions, they're leading up to the visual cortex within the occipital lobe. It's very, very common to have homonymous thinning of the paramacular region that goes along with the homonymous hemianopia. that you see on the visual field. So if you see a homonymous visual field defect, you know that the individual has a retrochiasmal lesion, either involving the tract, the optic radiations, or the visual cortex, the occipital cortex. Now, what I'm going to show you here is evidence of retinal thinning, hemiretinal thinning, in the setting of retrochiasmal pathology. There's a 21-year-old young woman who, at the age of 12, underwent a hemispherectomy of her left cerebral hemisphere for intractable epilepsy. She is now left with a right side hemiparesis. She has aphasia. Her visual acuities are pretty good. She's got 20/25 vision in the right eye, 20/20 vision in the left eye. She's got an afferent pupillary defect in the right eye, and she's got myelinated retinal nerve fibers in her left eye. Is purely an incidental finding. So here you can see in the left eye, these are her myelinated nerve fibers. If you look at her right optic nerve, you can see that she's got pallor on the temporal side. She's got pallor on the nasal side. And when you see this, this is something called bow tie optic atrophy. And it is the signature of a contralateral optic tract lesion. You're going to get an afferent pupillary defect in the eye with the bow tie atrophy. And when we look at the brain, we expect to see a contralateral optic tract lesion. So this is involving the right eye. That means we would expect to see a tract lesion on the left side, which would produce a right homonymous hemianopia. And here are the visual fields. You can see that there is a right homonymous hemianopia. But looking at the ganglion cell complex, what you can beautifully see here is that in the left eye, the temporal fibers that are going straight back. Remember, ultimately, these guys are communicating with the ganglion cell layer, the ganglion cell complex. So you can see that temporal to the macula, in the left eye, we have this thinning. And similarly, we have nasal thinning of the ganglion cell complex on the right side. So an easy way of thinking of this is that you get a right homonymous hemianopia that goes along with right homonymous thinning of the ganglion cell complex. And again, this is classic for individuals that have both optic tract lesions as well as optic radiation lesions. So if you're working somebody up for glaucoma and you see this, they may have glaucoma, but they've got something else going on within the brain. They've got a retrochiasmal lesion opposite the side of the hemifield thinning to the retina. In this case, a left hemispherectomy that resulted in the right homonymous hemianopia and this right hemifield thinning of the ganglion cell complex. Now, I talked to you about that. I said, beware of your glaucoma patients that present that way to you. Here's a 61-year-old man that has been treated within our glaucoma service who came in with these visual fields, meaning that he's got a left arcuate bundle defect superiorly in the left eye. Can't really see what's coming off the optic nerve in the right eye, but you can see that there is something of an arcuate bundle defect that is affecting his nasal field. But what you can see on the visual fields is basically this is a field within a field. He's got bilateral arcuate bundle defects, but on top of that, he's got a right homonymous hemianopia. So thinning, or rather, you have a nasal field loss here in the left eye. I'm sorry, going along with a temporal field loss here in the right eye. And if you look at his OCTs, what you can see here is that he's got this right hemifield thinning of the ganglion cell complex. Now he's got some other thinning that may be related to his glaucoma, but in a global sense, I mean, you can just, if you just look at these thickness maps, you can see pretty easily that there is this hemifield thinning. So I say to him, I said, if you ever had an MRI, if not, I'm going to order one. He goes, yeah, I had one not long ago, and my brother, I think he's got a copy of it on his phone. So he copies his brother, and his brother says, yeah, I got it on my phone, and I'm going to send it to you. And lo and behold, here you can see he's got this large porencephalic cyst. This is a large middle cerebral artery. This is a middle cerebral artery infarct on the left side of his brain that is responsible for his right homonymous hemianopia and this right hemifield thinning of the ganglion cell complex. So my point to you very simply is that when you see this, we talked about binasal thinning with a chiasmal lesion. This is homonymous thinning, to hemifield thinning of the macula. That's not glaucoma. That's not within the optic nerve. That's within the brain. And you say to yourself, well, how quickly does this show up? And the answer is pretty quickly. This is a nice paper from just a couple of years ago, showing that over time, this longitudinal analysis is that if the lesion is pregeniculate, and by and large that means it's in the optic tract, you're going to get that hemifield thinning on the ganglion cell complex typically within about a month. If it's behind that, if it's involving, say, temporal lobe, parietal lobe, or a combination, it's going to develop, but it's going to be a little longer, usually 5 to 6 months. So in other words, the closer it is to the eye, the quicker you get that hemifield thinning down. All right, so polling question number 3. Greg, are we ready for this? You want me to read it?
Yep, it's up and it's launched.
All right, great. So which of the following is an OCT characteristics of chiasmal insult? A, bitemporal ganglion cell complex thinning. B, binasal ganglion cell complex thinning. C, homonymous ganglion cell complex thinning. Or D, diffuse bilateral ganglion cell complex thinning.
And Len, while this is up and running, we have about 30% of the people rolling in. One of the questions came in from Carolyn Major, and it dawned on me that Carolyn is from Johnstown. You're
Not
from
only
Johnstown.
Carolyn from Johnstown, she went to Richland High School.
There you go. And I know you've met her. She's a rock star in OCT. She's out in Oklahoma. She's actually lectured for us at one of our live meetings. Len's going to be at a Pittsburgh meeting here in a couple of weeks, and I figured at least get you back home, maybe see some friends. And thanks for doing that. But there must be something about this area and being OCT geeks that are out there. So
evidently.
All right, we got a nice quick poll here. Yeah, people are still rolling in. I'll give it 1 or 2 more seconds. And okay. All right.
You want to give the numbers?
Yeah, it's pretty equal till we get down to the last one. 32% for your A. We've got 45% for B, and then 19 for homonymous, and then 5% for diffuse.
Okay, well, the majority has it. The 5% majority has it. It's binasal ganglion cell thinning. Remember, bitemporal ganglion cell thinning, you don't get that. Binasal ganglion cell thinning, those are the crossing fibers. The nasal fibers that cross, as they are damaged, they are going to thin down within the retina. So that's how retinal, that's how looking at the macula essentially lets you know that there is disease of, in this case, the chiasm or retrochiasmal visual pathways.
Perfect.
All right, so we've got, I'm not sure how much of this I'm going to be able to get through, but at very least I'll be able to get through the top one, and that's OCT and neurodegenerative disease. And I think the most compelling is the first one on the list, and that's multiple sclerosis. So you may say to yourself, well, why should I be doing OCTs on my patients with multiple sclerosis? Well, first of all, The eye is a unique structure in that it's the only place in the body that allows for direct observation and evaluation of non-myelinated axons. Because remember, for most individuals, they lose that myelin sheath to them whenever the axons are traveling within the retina. The other thing is that over the past 10 to 15 years, we have seen many publications coming out looking at the value of OCT, both nerve fiber layer as well as ganglion cell complex findings, as surrogate biomarkers of disease activity among individuals with multiple sclerosis that are very close as it relates to these findings mirroring what we see as it relates to disease progression on with serial MRIs. And then finally, that's why OCTs are now becoming mainstream as it relates to incorporation as part of the protocol in the evaluation and management of patients with multiple sclerosis. So very simply, what does that mean to you as an optometrist? Most of the neurologists that you're going to be working with probably do not have OCTs. You're going to be inheriting their patients to do the OCTs, send them the results, send them a report so that that can go along with whatever the findings are, whatever is going on with their serial MRI. So we can think about OCT findings in MS, both those with optic neuritis, those without optic neuritis. Now, with optic neuritis, early on, you get a little bit of thickening of the nerve fiber layer and the ganglion, and the ganglion, you get a little bit of thickening of the nerve fiber layer, but that thins down very rapidly. So that typically within about 3 months, as their vision is getting better, their OCTs are looking worse. And you get this significant thinning down, up to about 40% overall thinning of both the ganglion cell complex as well as the retinal nerve fiber layer among individuals with demyelinating optic neuritis. So here's a 45-year-old woman who develops optic neuritis in her left eye. Visual acuity is 20/20 in the right eye, 2500 in the left eye. She's got an afferent pupillary defect in the left eye, and she has pain whenever you ask her to move her eyes around. And at baseline, you look at her OCTs, both of the nerve fiber layer as well as of the ganglion cell complex, and overall, everything looks pretty normal, with the minor exception, as I'm pointing to here, in the inferonasal quadrant of the left eye, where she's got a little bit of thickening of the retinal nerve fiber layer. Now, this is baseline. Vision is 2500. Here she is 3 months later. Vision, or 2.5 to 3 months later. Vision is now improved to 20/20. But look at what's happening to the OCT. You can see that the nerve fiber layer is thinning itself down, and you get this global thinning down of the ganglion cell layer. And then about 6 months later, about 6 months from baseline, you see that the visual acuity is stabilized now at 20/20, but now we have quite a bit of thinning of the retinal nerve fiber layer as well as of the ganglion cell complex. So essentially, this is what's happening. In the normal eye, nerve fiber layer is staying constant. In the diseased eye, the nerve fiber layer has gone from being a little bit thick to progressively thinning itself down. So that's a paradox that you see among individuals with optic neuritis, is that initially their nerve fiber layer is a little thick and their vision is bad, but as their vision gets better, the nerve fiber layer progressively thins itself down. That's the normal evolution. Here's a 31-year-old woman, 10-year history of relapsing multiple sclerosis. She is now on infusion therapy with ocrelizumab, infusion therapy every 6 months. She previously had an episode of optic neuritis in her right eye. She's had good recovery of vision, which is typical, 20/20 in the right eye, 20/20 minus in the right eye, 20/20 in the left eye. Looking at her optic nerves, a little bit of temporal nerve fiber layer, a little bit of temporal pallor in the right eye, fairly normal appearance to the optic disc in the left eye. And what you can see is if I blow these nerve fiber layers up, is that in her right eye, she has this very pronounced thinning down of the retinal nerve fiber layer. That's why I'm pointing to you here with the arrow. But if you look at the temporal nerve fiber layer in her left eye, That's in the eye without the optic neuritis. She also has thinning. So what's up with that? Well, this woman has multiple sclerosis. And we know pretty well now that individuals with multiple sclerosis, even in the absence of optic neuritis, you can get thinning of the nerve fiber layer and the ganglion cell complex over time. And this tends to mimic what is going on as it relates to disease progression through other measures, notably serial MRIs, as well as looking at the EDSS score. Now, you don't get as much thinning as you do with optic neuritis, but you do get it. So this is a landmark paper. This is one of Dr. Laura Balser's slides back when she was at the University of Pennsylvania. And this is a study that they did in 2008 showing exactly what I just said. And that is that individuals with multiple sclerosis in the absence of optic neuritis, these folks can show thinning of the retinal nerve fiber layer in the absence of optic neuritis. Now, what do we know now? Well, if you're thinking of the retinal nerve fiber layer, to make this very, very simple, we look for temporal thinning or infratemporal thinning of the retinal nerve fiber layer, going along with global thinning of the ganglion cell layer, ganglion cell complex. You don't get that hemifield thinning that I talked to you about with retrochiasmal lesions or binasal thinning that we get with the chiasmal lesions. And you don't get those notched areas that you see with glaucoma, you know, the nautilus sign that the glaucoma folks like to talk about. It is generalized thinning of the ganglion cell complex. So temporal thinning of the nerve fiber layer, global thinning of the ganglion cell complex. Here's a 30-year-old woman, history of relapsing multiple sclerosis. She is also undergoing infusion therapy with ocrelizumab. No prior history of optic neuritis. Visual acuities are normal, 20/20 in each eye. Looking at her MRI, she has quite a number of supratentorial paraventricular white matter lesions. Some of these are enhancing with gadolinium, some of them are not. So that's her relapsing multiple sclerosis. Remember, she does not have optic neuritis. But if we blow up her ganglion cell, or I'm sorry, if we blow up her nerve fiber layers, what you can see is that she's got this bitemporal thinning of the retinal nerve fiber layer. Now you get that with multiple sclerosis. The issue is not so much whether you have it or not. If you have it, that's significant. And certainly you want to report these findings back to the neurologist. But what's more important than that is following them over time. And I like to see these patients on a 6-month basis. It's pretty easy to get them in 6 months and simply repeat this non-invasive OCT. And what we're looking for is progressive thinning over time. So you got to get those reports back to neurology. Is the OCT stable or is it progressively thinning down? Now, this is a nice paper from a couple of years ago, essentially showing what I just talked, validating what I just mentioned. And that is that you get both nerve fiber layer, this temporal thinning of the nerve fiber layer, as well as diffuse thinning of the ganglion cell complex among individuals that if it's progressive disease, to a large extent goes along with the progressive findings that are noted on MRI. So what this tells us then is that OCT is a reasonable surrogate marker of disease activity. Does it replace the MRI? Absolutely not. But it can be helpful if the neuroradiologic findings are otherwise equivocal. So serial OCTs are your MS patients with reports getting back to neurology. So polling question number 4. Which segment of the retinal nerve fiber layer is most likely to show thinning in the setting of multiple sclerosis? Is it A, nasal quadrant, B, temporal quadrant, C, superior quadrant, D, inferior. So what part of the nerve fiber layer is most likely to show thinning in the setting of multiple sclerosis? Nasal, temporal, superior, or inferior?
All right, it's rolling in here nicely. Look at that. 80% live and active. All right. Perfect. I'm going to just end it here, Len. And
Okay.
I think we've got ourselves about 14% nasal, 80% temporal, 4 and 2% superior and inferior.
Wow, this is a great group because the 80%ers, you guys got it. You're killing it. Excuse me. Temporal, remember, keep it simple. MS patient is sent to you by neurology. You're seeing the patient, and the question simply becomes, is that, what is going, what are you looking for? Is there, patient has MS, what are you looking for on the OCT? Two things: temporal thinning of the nerve fiber layer or global thinning of the ganglion cell complex. Just about that simple, or both of them.
So there's a question that rolled in here. It says, will thinning on OCT of MS patient change the patient's therapy with neurologist?
Yeah, that's a great question. As a general, it depends. It depends. A very simple way of saying that is that, if the individual is showing worsening on the OCT, if their relapses are going up, and certainly if the MRI is suggesting an increased lesion burden, the answer is yes. Now, what about an individual that has increasing relapse rate? The MRI is equivocal, but they're showing this progression on the OCT. Yeah, that is progressive disease. Now, as I said before, it's not so much a matter of relying solely on the OCT, but it is a matter of trying to marry the OCT with the other findings, the clinical examination of the patient, along with the lesion burden, as is evidenced on MRI. All right, Greg, it's about 8:45 right now. What do you want to do? Should we move on, or should we call it quits?
Let me see here. A question just came in. You know your slide deck better than I do. If you think you have a pearl or two you want to wrap up with, that'd be great. If not, let me do this. It says, my wife's neurologist knew nothing about OCT scans. How knowledgeable are they in general about these? So neurology and OCT.
That's a really good question. It is becoming much more popular. I think that in the areas where you have academic medical centers, to a large extent, it is part of standard of care. If it's outside the realm of an academic medical center, it's iffy. But the best thing I can tell you is that the data, the literature supports the use of OCT as a surrogate biomarker. It's just that simple. But I think you bring up a good point within the question, and that is, do not expect neurology. I mean, you can't just. That's like sending a visual field back to a neurologist. That's not necessarily their game. Sending an OCT back, just the scan back, that's not necessarily their game. You own that. It's the eye. So it's very, very important to be sure you can send. Sure you can send the scan back if you want to get extra fancy. But the most important thing is to send a report back answering one of two questions. Is it stable or is it getting worse? Stable or progressing? Just that simple.
Question rolled in, will insurance pay for an OCT with a diagnosis of MS? That's a tough question on kind of a national audience. There's all these kind of, regional and local payer type of determinations that are out there. Maybe, but you could probably go to more of things like optic atrophy, nerve loss, and things like that will help. Yeah.
Exactly. I was going to say, as long as there are no CMS agents on this evening's webinar, you can code these individuals appropriately as other optic neuropathy or other optic atrophy. Other optic atrophy is a pretty good catch-all. It's not a it's a code that is recognized by all payers. It is something that you can definitely substantiate in these instances. And it sort of gets you around that whole that whole conundrum of will they or will they not reimburse for a pure diagnosis of relapsing or another form of multiple sclerosis. Yeah, that's a great point, Greg.
So Len, let me do this. You have Parkinson's, I believe, and Alzheimer's. We got a couple questions rolling in here. At least one came in. It says, can you comment on the findings? So can you just maybe, give us the rapid fire of like the pearl of Parkinson's, the pearl of Alzheimer's, and then we'll just wrap it up.
Absolutely. I'm going to do these individually. I'm going to go to the summaries. Parkinson's disease. Do they have thinning of their OCT? You better believe it. And it's fairly similar to the thinning that I've just discussed with multiple sclerosis, in that it seems to be on the nerve fiber layer more temporal as opposed to other quadrants, and that the ganglion cells, it's more of a diffuse thinning down. And it kind of makes sense because if you think about it, the retina is replete with dopamine receptors. And the dopamine is released by the is released by the amacrine cells within the retina. Essentially, it's released by the supportive cells within the sensory retina. So it stands to reason that an individual that has an inability to produce dopamine within the brain as well as within the eye, that ultimately this is what is required for the retina to thrive. If the retina can't thrive, you're going to get a thinning down of the ganglion cell complex, and that's going to translate into the optic nerve, a thinning down of the nerve fiber layer. Now, what about with Alzheimer's disease? Same thing holds true. It's a little bit more difficult to say what quadrant is involved with Alzheimer's dementia, but here again, both thinning of the nerve fiber layer as well as thinning of the ganglion cell complex, very, very common, not just with Alzheimer's dementia, but also individuals that have the precursor, that is mild cognitive impairment. Now, the reason that I would say that that's important now is because you have a couple of pipeline drugs that within the past couple of years have been approved for the treatment of Alzheimer's disease, because they are largely thought to be, at least to some degree, being disease modifying. Now, I'm not going to get into the controversy as to whether they are worth the cost, whether they should have been approved initially or not. And I'm not going to get into what prompted one of the major drug manufacturers of reducing the cost from $56,000 a year to $28,000 a year. But I think it's significant from this standpoint, is that you've got some disease modifying agents that are now approved. What that means is that I think you're going to see Medicare approving some of the studies that are more mainstream as it relates to pinning down the diagnosis of Alzheimer's dementia, above and beyond simply doing a physical exam for the patient. And that includes PET scanning. And I think that OCTs will eventually get there. So once again, is an optic neuropathy common with Alzheimer's disease? You better believe it. So, checking these individuals, evaluating them periodically, be it 6 months to a year. OCT is a pretty simple test to do, and it's fairly inexpensive. And as newer agents come online, may be a surrogate biomarker to go along with PET scanning, MRI, MR spectroscopy, and other studies. So I think that it's worthwhile bringing that up right now as something to at very least consider for your patients that have Alzheimer's dementia. Now, a very simple way I think of summing all this stuff is that people that have neurodegenerative disorders, common ones being MS, Parkinson's disease, Alzheimer's dementia, all of these guys affect the optic nerve, all of these guys affect the retina. And that the OCT is a simple way of being able to, at least indirectly, look at damage to these structures, but probably more importantly, is to be looking at these individuals longitudinally over time. That's where I think the real value is. Looking at a simple, cheap, effective way of gauging progression over time. And maybe that's a good place for me to end up.
Yeah, that's a great point. And now I'm just going to wrap up by echoing and saying it a different way is, retina is brain, right? The retina is the brain, neurons. And that's why you're seeing these changes OCT wise and understanding the pathways. You hear a lot about, nutrition in the brain going back and forth. So just remember, retina is brain, and you'll understand why OCT is very valuable in these neurogenic disorders. So, Len, you hit a home run. We knew you would. I'm going to see if I can share my screen here and just say, thanks. We got the questions as we rolled in here. Starting to get your virtual round of applause. Great lecture. Wow. Excellent lecture. Thank you. Thank you. You can turn on your chat box there if you want and look at your virtual round of applause, and questions have been taken care of. And I want to thank everyone for taking OCT and neuro-ophthalmic disorders synchronous virtual course. Glenn, you took something super, super complex, was able to boil it down, speak our language, and give us lots of pearls to help us in our clinic. Thank you very much.
My pleasure.